This is a short case capsule. We recently performed an intranodal lymphangiography followed by thoracic duct embolization for one of our patients presenting with recurrent chylous ascites. So this is a short case demonstrating the same. So we had a 62-year-old female. She was post CA stomach. She had undergone a surgical correction for the same in March 26. Following that, she developed recurrent chylous ascites, multiple tappings done, almost 4 to 5 liters drained per week. She was referred for an intranodal lymphangiography followed by a thoracic duct embolization since the fluid was confirmed to be chylous in nature. So these are the spot images showing the intranodal lymphangiography that we did using the right inguinal as well as the left inguinal lymph nodal axis. We performed the lymphangiography with a total of 20 ml of lipiodol mixed with contrast in a ratio of 1:1 till we had the opacification of the entire thoracic duct. Now, since in this case the cisterna chyli was not very well demonstrated, what we did was that using combined ultrasound as well as fluoroscopy guidance, we planned to do a direct puncture of the thoracic duct at the level of its entrance into the IJV. So this is a video showing the cannulation of the duct using the micropuncture set, failed attempt during the first cannulation. This video showing the successful cannulation of the thoracic duct using the micropuncture set. This was a direct entry at the bulbous portion of the thoracic duct where it joins into the internal jugular vein. This is a Fielder FC single wire which we have used to then cannulate the duct. Again, passing of the single length wire through and through along the entire course of the thoracic duct, which was then replaced over this with the micropuncture access kit and a ProGrade microcatheter. This is again a lymphangiography with contrast showing the active extravasation of contrast along the lateral aspect of the thoracic duct, demonstrating the site of leak. Following this, we performed glue embolization of the entire thoracic duct, both proximal and distal to the leak, along the entire course of the thoracic duct. This was using 50% of glue using the ProGrade microcatheter itself. This is the coronal image showing the entire glue opacification of the thoracic duct, both proximal and distal to the site of leak, as well as opacification along the leaky channels as well, as demonstrated in this video. Following this, we did perform a cone beam CT. So the cone beam CT clearly showing the glue opacification of the thoracic duct, as well as the contrast extravasation along the lateral margins of the thoracic duct where glue has also been opacified, again confirming good embolization of the entire duct. We do have a follow-up of this patient. So we have a 4-week follow-up. The drain output progressively reduced initially to approximately 250 ml per day, then reducing to almost 50 ml per day. The last week output as of August 26 was less than 10 ml per day, and the drain has now been removed.